What if I told you most relapses could be predictable? I'm Dr. Arwen Podesta, functional integrative psychiatrist. I'm triple boarded in adult psychiatry, addiction medicine, and forensic psychiatry. I love helping addiction professionals improve patient engagement and recovery outcomes using integrative, evidence-based strategies. In this video, I'm sharing tools that make it possible. When most people talk about relapse, they treat it like a surprise, like something that just came out of the blue. It just happened out of nowhere. And even in clinical settings, we often reduce it to just a moment, sudden. The patient picked up, they used, they relapsed. But what if we were really paying attention deeper? Relapse doesn't start the moment a substance is used. It starts long before that. The real problem is this. Most of us are trained to focus on the surface behavior, on sobriety, on compliance, on negative drug testing. But those metrics can trick us into thinking that someone is actually stable, when inside they're actively unraveling. The patient is technically doing everything right. They're showing up, saying the right things, abstinent, but you can feel the tension. You can see the grip in their jaw, hear about how they talk about their stress. Oh, they have cravings. They are out of control and they're not recovering. Maybe they're abstinent, but they're not recovering. They're just merely surviving. And this is where it gets dangerous. That survival mode, think of it kind of as white knuckling it, the forcing it through each day version of sobriety. It doesn't last. Eventually something gives. A trigger slips through, a mood crash hits. A moment of pain opens up a flood they haven't learned how to process. And suddenly, what looks like progress just collapses. And it's not because they failed, not at all. It's us. We missed the signals. So if we want to prevent relapse, we have to shift how we see relapse. It's not a failure of willpower. Relapse is a failure of early detection. And once you learn to read the early warning signs, the emotional patterns, the body cues, the belief systems underneath it, you can begin to intercept it before it spirals. I've had so many patients over the years who came into my office technically doing well. They were abstinent, their toxicology screens were appropriate, they were checking the boxes, they were in support sessions, they were in therapy sessions, and they made lifestyle changes even. But underneath, they may have been stuck. These were people who, they'd stopped using, but they hadn't truly started healing. And you could feel it in the way they spoke. Tension, their rigidity, they were guarded or easily irritable. They were avoiding triggers like the plague, not learning how to move through them, managing their behavior, but not really regulating their nervous system or processing the grief, processing their shame, processing their trauma still living in the body. And over time, that internal tension builds. I've seen it happen over and over. The patient goes through a rough week. Maybe it's a relationship stress. Maybe they're exhausted, or maybe something subtle hits a nerve that they didn't even know was raw. Suddenly, they're overwhelmed. Their coping tools feel miles and miles away. They spiral, and eventually they might pick up. And when they come back to see me, they feel like they failed. But what I always tell them is relapse didn't start last night. It didn't start when you reached for the substance or called your dealer. It started probably at least days, if not weeks ago, when your body was sending the signals to your brain and your brain was overriding those signals. It started when you were pushing through, not tuning in. And that's where we lost the thread, because if we can spot that moment, the shift into survival mode, the numbing, the internal shutdown, we have a chance to interrupt it. So let's talk about why this happens, because once you understand the underlying patterns, relapse stops looking like chaos and starts looking like a signal. Here's what we often miss. Relapse doesn't live in the behavior. It lives in the build up to that behavior. When someone starts slipping back into old patterns, it's rarely about craving alone. It's usually something of a combination of emotional, physiological, cognitive breakdowns stacking quietly, invisibly until something tips. First, there's the emotional undercurrent, and many of our patients carry lots of trauma and grief, abandonment and shame. And when those emotions stay unprocessed, they don't go away, they get hidden, they go underground. So the patient says, I don't know what happened, I just snapped. But what really happened was weeks of emotional static building up that finally broke through their defenses. And there's the physiological side, which is also often overlooked. Think about if you have dysregulated blood sugar, if patients have inflammation, poor sleep, imbalanced neurotransmitters, nutrient depletion. All of these affect mood, coping skill response, stress response, and impulse control. I've had patients relapse simply because they weren't eating enough protein and were crashing every afternoon. It's not dramatic, but it sure is powerful. The body sets the stage for the mind. Then, of course, there's cognitive distortions. Those cognitive distortions, boy, they can creep in. I'm never going to feel normal. I can't do this forever. I'm one bad day away from blowing it. These beliefs become self-fulfilling. They fuel shame, and boy, does shame isolate. And isolation is fuel for relapse. So when we zoom out, if we see the truth that relapse isn't one bad choice, it's a convergence of ignored emotions, of dysregulated systems, and hopeless internal narratives. But once you learn to see those patterns, you can intervene before it reaches that tipping point. You can stop trying to treat the relapse and start trying to treat the process that leads to it. And if that shift in perspective is resonating with you, if this kind of content is helping you rethink how you support your patients, go ahead and like this video and subscribe to my channel. It's the easiest way to let me know that you want more tools like this and to make sure you don't miss out on what's coming up next. So the question is, how do we actually use this in practice? How do we, as busy clinicians, move from reacting to relapse, to recognizing its roots early and stepping in before the spiral? It starts with shifting our lens from behavior management to pattern recognition, from did you use to asking what's shifting inside you lately. And from that place, here's how I approach it in my clinical work. First, we teach patients to track their internal state, not just their external behavior. That means helping them notice what's going on beneath the surface. Physiological cues like fatigue, tension, racing thoughts, or even low-level dread that creeps in without explanation. Interoceptive awareness practices can help here so much. So can tools like mood log, breathwork, even biofeedback and neurofeedback, anything that brings the patient back into their body and shows them what stress actually feels like in real time. Because if they can feel that shift coming, they can interrupt it. Okay, next we target the narrative. When a patient starts spiraling into thoughts like, I'm not doing enough, or I'll always be broken, feeling victimized, we don't argue with the thought. We bring that thought into the room. We externalize it. We want to label it. We want to ask them where that thought came from. When a patient starts to recognize their inner critic, not as the truth, but as a voice shaped by past trauma or by unmet needs, they can start to respond to it differently. And that reframing isn't just mindset work, it's actually relapse prevention. And finally, we have to stabilize the body. This is the piece that often gets missed. If someone's nutrient depleted, sleep deprived, inflamed, they're living in a body that feels unsafe, even if their mind is trying to stay positive. So I bring in all the functional medicine tools as able to assess inflammation, blood sugar swings, nutrients, gut health, and more. No matter how skilled a patient is emotionally, if their physiology isn't working or it's working against them, they're swimming upstream. And when you address those three levels, emotional regulation, belief systems, and physiological stability, you don't just reduce relapse risk, you create actual embodied resilience. So relapse isn't a random event. It's a culmination. It's a pattern, a process, a message often whispered through the body long before it ever shouts through the behavior. And when we as professionals learn to tune in to those early signs, when we teach our patients how to listen, how to interrupt, and how to reset, we stop chasing symptoms. We start helping our patients build their own true recovery. Recovery isn't just about staying sober. It's about building capacity. It's about wholeness, creating a life that doesn't need numbing to be bearable. If this shifted how you think about relapse prevention, I invite you to keep going. The next step is understanding why our current models sometimes fall short, even when they're evidence-based. That video is waiting for you next, and it's one I wish every clinician had years ago. Until then, stay curious, stay grounded, and most of all, keep practicing in a way that brings healing, not just control. I'll see you there.